Sunil can keep his video on, doesn't matter. We are all having our own night, no problem. Enjoy.
Sir. Sunil sir.
And very nice to meet old friends. And a lot of people are joining to this, like having a virtual executive committee meeting. Dr. Gore is with us already. Aroop must join me in a minute. One chat, participant 2 list. Yes, they will be joining. Don't worry. 9:30 the time. 9 o'clock the time. Not everybody's comfortable time. Diwakar. Dr. Diwakar,
Yes, yes.
can you start
Yeah, sure.
extemporaneously? Start
So,
extemporaneously.
good. Participants are joining slowly. So let us start with the history now.
Good.
When we were students in MBBS, orthopedics was part of surgery.
Yeah, you have to be louder.
Because I,
Your
is it clear now?
close to you. If you're using a phone, keep it close to you. No, still not clear.
It's still not clear.
Now clear.
So when we were the students, orthopedics was the part of surgery curriculum. And we have been taught orthopedics and surgery. And we joined PG, then orthopedics was a separate department. So the branch is evolving and it will keep evolving. Anyone who thinks that I know everything, he is definitely wrong. Science will never stop. And orthopedics is the branch which never stops surprising you. Sometimes you think I am doing the best, that will be the worst thing in future. So keep pace with the time, and then time keep pace with you. So now what commerce is? I have been talking to some of the doctors. The beginners, they say that we have to pay installments. And for paying installments, they say at least 4 surgeries are must in a month. So all right, 4 surgeries you do, no problem. But one should not do injustice. Injustice means today I had a small girl. She had torus fracture of the upper humerus. I knew it will be all right if I don't treat. But someone has told her that she will need some surgery, operation like that. And I knew that lady, she will not be able to afford 100 rupees. But if I say, go home, do nothing, then they so we have to keep a balance between the patient's monetary conditions and satisfaction. Should be the third most thing. What we need, we can earn from others. I never say that surgery is wrong. I never say plaster is wrong. I don't say you don't charge. You can charge for even plaster. Keep patients satisfied, first aid. Keep up to the expectation of the patient. They expect from us, that should be fulfilled without harming the patient for the pocket of the patient. Do not try to fleece them. You can cheat. So, because as Dr. Sarmiento has written in his book Bare Bones, that most of the orthopedics is captured by the implant companies. You must have seen in conferences that implant companies paying in crores. And what they get in return, definitely, they get in return by rising the cost of the implant and making you believe that implant is the only thing which can make bone unite. But as Dr. Prakash said, bones unite even in presence of implant, not because of implant. In spite of the implant, bone unite. They don't unite because of the implant. And the Elizarov surgeons, they all know that Elizarov used to tell that osteum is mother of the bone. Periosteum, you are depriving bone of the mother, and endosteum is the father of the bone. And if you block the both, you have made the bone on the God's mercy. It unites, so it unites in spite of the challenges and the damages you have done. And second thing which I may tell you, bone is not a dead thing. Bone is a highly lively thing. You can see any more dead or dying bone. I have seen it surviving. I have seen a photograph Dr. Prakash has posted. That below only tibia and fibula is there, black in color. But I expected if someone is ready, I can revitalize that bone even. So any more dead looking bone, it can be regenerated and renovated. So don't consider bone as a dead thing. It's lively. And with the care, like a gardener. I can call surgeon as assembler.
You participants to please mute their recording, please. Mute their audios, please, so that the speaker can speak. Thank you.
We are made to believe that every bone should be anatomically reduced at every cost. But when I see the treatments by neurosurgeons, they never try to align the bone. They know how the function is going to come. Same thing I have seen in dentistry also. They don't try to align. They align only teeth only. They don't align bone. So functional outcome is first, bone assembly is second. But we have turned ourselves into the carpenters and assemblers and bone synthetics, not bone revivers. So it's my tenet, revive. Do not do injustice with the bone. Do injustice with the pulse of the patient. That is allowed. But do not unjustify your treatment to the bone. You can treat any way you like, but do not harm. This is all. Once Dr. Anil Dhal, he is in MAMC. He has been asked by not earn money. So he said, I don't teach commerce. I teach only orthopedics. So that's what I also say. We teach orthopedics. We are not here to teach the commerce. That you can learn anywhere and do anything. This is all. So this is my blessings to all. That be sincere to the bone. Don't be sincere to the pulse of the patient. Okay.
Thank you, Dr. Diwakar. I think I will ask Dr. Sunil Chowdhary to just join us and give us his views about commerce and orthopedics. You have to unmute your mic. You have to unmute your mic, yes. Sunil, unmute.
Am I audible?
Yes, you are now audible.
Oh, thank you. Good evening, everybody. And as far as Dr. Arvind Diwaker has narrated the whole story, everyone has got their own point of view. Most of the young surgeons which I have come across, they have never been taught that modeling of bone is there. They don't need. Hello?
Yes.
So most of the young surgeons, they never have been taught that you have not to align the bone, especially in the kids, especially the person who have got potential for the growth. That means even if the bone are lying side by side, They will unite and they will remodel. They never have been taught like this. And in the metro city where there are big colleges or medical colleges, most of the senior person, I'm afraid to say, they have moved into the replacement. So what I have talked to many young surgeons, they have never been taught. And whatever the teaching they have done, either by themselves or by seeing the access or by the senior, just senior to them, not the very old person or whether senior most have got everything in experience, like what can be done in young, what can be done in adult. So I met few of the person, few doctors whose son, they just completed the orthopedics and they wanted to fix every bone. They say without fixing, how can they unite? When I got the access, when I shown the album, then only they were convinced that the bone can be united with the remodeling. So the problem not only with the kids, they have never been taught. And secondly, the commercial factor, especially in the places where they have to meet the demand of the hospital and they have to survive. So they think just by operating, they will get quick money. So they are lured into this and they want to operate. So you just simply can't blame the young surgeon that they are doing just only for the commercial purpose. Both things are there. They don't know the facts. And secondly, they are pressurized. Hello?
I'll conclude the new entrants, please. One minute. Mic is on.
Hello?
Yes, yes, we can hear you. We can hear you.
Hello?
We can hear you.
Prakash sir, I think I have made my point very clear.
Yes, yes, yes. Very, very clear. Very, very clear. Very, very clear.
Okay.
1 minute. I think I have somebody who has got. One minute. Yes, we have muted him. Somebody was on with the TV in the background, so it was causing us problems. As more and more member joins, we'll get some disturbance in the background. Thank you very much, Sunil.
Thank you, sir.
Let me add 2 points worth and then get back to Dr. Gore. Next speaker will be Dr. Gore, and he's going to give us some. Sorry, 1 minute. Let me add him as a spotlight.
Yeah, I'm okay. That's fine. No need of spotlight.
Okay, no need of spotlight. There is no photograph. So basically,
Okay. Yeah.
speaking
Can I start?
Yes, you are clear. Just 2 minutes. We have been speaking about trauma. So I thought that we will just ask Dr. Gore to speak to us and tell us about his views on how commerce is modifying orthopedics.
Yeah, okay. My perspective on this topic is very, very different. Primarily because of two things. Number one, I personally feel that the industry is very, very shrewd and very intelligent to utilize a part of orthopedic fraternity, their guns on their shoulders and shoot at us. I mean, if you look at the reality outside, you will find that there are two groups of orthopedic surgeons, one who are very favorite with the industry, but the industry doesn't come in the field openly. They take recourse to probably supporting various glamorous conferences, etc. And then these people who have no relation with the ground reality, just because they have some professorship or an attachment in a teaching institute, continue to talk about things which become more and more obsolete and more irrelevant. I'm very blunt about it because this is what I have seen every day over the last several years. I'm in practice for the last 38 years, out of which I have devoted myself to transfemoral endoscopy for the last 20 years. And I have no hesitation in saying that in spite of all goody-goody talks with various friends and well-wishers, we have been unable to get our thinking, our way of approaching the problem in the mainstream. Why? Because all those who are occupying those positions where they can mold the younger surgeons feel extremely insecure the moment we start talking the real relevant science. That is number one. Number two is when an orthopedic surgeon in training is working, he has to work to the pleasure of his teacher. I mean, I know that tomorrow, if we relieve or if we sort of take away the condition that my thesis has to be signed by my teacher and my thesis has to be his pleasure, his expectations, whatever. If we remove that condition, I'm sure that much more innovation, much more rebellious spirit will come to orthopedics. Today, we are just creating semi-slaves because you need to please your teacher, and then naturally medical science and teaching being very hierarchical, whatever your senior says, probably you will carry on. Whether it is good, bad, ugly, you don't care because you have to get through the exam, etc. Now, the real transition comes when you go into practice. And nowadays, a very, very bad thing has happened is your senior, your teacher, whosoever, your guide, they immediately start treating you as a competitor in practice. The older bonhomie or the older relation of a teacher and student no more is valid. The day you pass out, you're a competitor because you're going to eat away the cake which probably select people were eating. And therefore, the younger person who comes out in practice, who doesn't have any idea how it works outside, how it works in private practice, is at a loss to know how to go ahead, which problems are really important. I'll just take one more minute and then stop. The real problem, for example, in spine is on one side, everyone says that 80% of the patients need conservative care. In some people's mind, it could be even 90%. And only 10% or maybe 20% people need surgical intervention. Now, you have a huge number of people who do not need surgery. But I can tell you that there is hardly a single medical institution which will teach you how to diagnose pain, how to differentiate inflammation and mechanical compression, how to differentiate a patient needing surgery and not needing surgery, how to monitor the non-operative care, etc., etc. And in all this, the industry plays a part because they don't allow you to concentrate on what is important. For example, all our spine conferences, more than half the time is spent on implants, is spent on stabilization. I mean, it is so laughable that number of people doing deformity surgery may be a few in tens, whereas 80%, 70% of the time of the conference is spent in talking about deformities and stabilizations and all those, I would say, maximally invasive and morbid surgeries. And lastly, I would say that the agenda setting or setting the narrative for academic practice in orthopedics, as far as I'm concerned, in relation to the spine, is completely set by the industry. They would only highlight failed back surgery, then they will highlight stabilization where it is proven that it has a role in trauma and instability, nowhere else. But you will find they will always talk of degenerative spine and stabilization, etc., etc. So that's my view on this issue. Thank you.
Thank you very much, Dr. Gore. I think I will give the mic next to Dr. Kiran Patel, and then Dr. Mukherjee will enlighten us with his wise talks. Dr. Kiran Patel, unmute your mic and please come online.
Hello, everybody. Glad to see you. Now, I want to put one slide. I'm sharing my screen.
Yes.
So this is now the orthopedic surgeons. The moment we pass out from the college, we are all branded by Synthes, Zimmer, everything. But recently I saw on Twitter by very well-known author from Canada. Everybody knows Paul Tornetta. We should ask one question: why we are in OR first, rather than how we will perform in OR. I'm sending my slide to Dr. Lakshman later on. It is a lecture given in OTA platform. So even if such a precise fixator of bone, if he thinks that the first question he should ask, why I should be in OR? And we all, right from Dr. Prakash, Dr. Diwakar, and we should ask first question, why should be in OR rather than how we are doing it, how we are going to do it in OR. That's my question. And agree with Dr. Gore. Everybody is after profiting and money and everything. We all know that implant cost and implant rather pushing on the this baby mind will create a havoc, and we should be afraid of primum non nocere. We should not do harm first. Let nature has its own potential of healing, right from veterinary to birds and everything. They all heal well, and especially for orthopedic, we know the healing potential. We should not disturb biosphere, that is fracture of sphere, what I term it as. Rather, we should have a biological aspect of fracture fixation or any normal course of the any disease. We should know that and we should follow that. So this is my slide, and rather a baby orthopedic surgeon is right from the birth is fed with this picture. Thank you, sir.
Thank you, Dr. Patel. You can stop sharing your screen.
Okay.
And we'll ask Dr. Aroop Mukharjee to come on spotlight. Wonderful. 1 minute. Yeah.
I have unmuted it. Can you hear me all?
Dr. Kiran has not stopped sharing his screen.
Okay, please.
We are on.
Okay, I am done.
Wait. There we are.
Can you hear me now?
Yes, Dr. Mukherjee. How is your health now?
I'm all right, keeping fine.
Beautiful.
But only, yes.
Everybody was waiting for your words of wisdom, pearls of wisdom.
It's nothing. I think what we already heard from Dr. Patel and Dr. Gore and Sunil, we were talking about what is happening which we don't like. We like that you do whatever you like, but you should not be straying away from the truth, and truth means science. Till the absolute truth doesn't come to our knowledge, we should be striving to achieve what is more nearer to the absolute truth. This is my humble suggestion. Now, what are the students learning is what they are being taught. They are not allowed, or they now, with the access of new media as well as with the WhatsApp University, they have got an access. Many of the students know what is endoscopic spine surgery, what is a total knee. If they have not done it, or they have not seen it in their own hospital with the limited resources, then they can see it in. So teaching is not an issue. The issue is, first thing, they have to get an MS done. once they have done their MS, then they are allowed to practice on their own. Secondly, every student is a model of his year, just like the cars. We ask our friend what model it is. That means what are the facilities? We just know with the model of the car, then what are the features of this car? But the basic science features are the procedures that you can add on to many procedures of the subject. But what are the indications of the procedures? And what are the basic science behind that procedure is not changed. The spine anatomy will not change. Spine degeneration will not change. The arthritis of the knee will not change. The pathophysiology following an arthritis in the entire body will not change. A lot of people will be, when you are talking about this ignorance about fractures, you can imagine what is the ignorance about the disease. Now, an orthopedic surgeon thinks that he's not bothered about the liver, kidney, as far as they are functioning well. An orthopedic surgeon is not bothered about the condition of the heart, or he wants to know the condition of the heart, whether the patient is fit for surgery or not. The orthopedic surgeon is only concerned that the arthritis affects the knee of the patient. So if you replace the knee, the arthritis is going to be left behind in the hospital, and a healthy patient will come out of the hospital, leaving the disease in the hospital. So these are the things which we need to discuss with any young orthopedic surgeon, and he should know about it. Whether he's interested to learn about it or not, that is his choice. These are grown-up men who have, most of them have started their married life. They have got their own kids and responsibilities, but they should be aware of what is science and what is being practiced. It is similar that if most of us take a driving test at this age, we will fail because we overlook certain basic safety requirements or procedures in driving a car, because we take these things for granted. But again and again, we will have to reiterate in the minds of these young surgeons that, look, this is the science. Your arthritis is not living in the knee, or your arthritis is not living in the spine. The body is being affected by a chronic disease which takes a toll of the system over the period of years. And this is the way to reverse the disease process. You can see if the knee is badly out of shape, or it is grossly degenerated. So you can make a quick change by replacing the knee. But the changes with which the body is suffering for the last many years need to be addressed as well. You can't change the tire of an old car and think that it has become new. The engine is also needs a service, and the electronic system also needs a service. So that is what I want to tell an orthopedic surgeon, that be a doctor first. You should touch the patient. You should also see that his blood pressure is all right. And you should also be concerned about his family. How many people are there in the house? How is he being, looked after? What is his financial support? And what are the other comorbidities he's suffering from? So this is what my little idea is. Let them be exposed that orthopedic surgery is not only read about bones, joints, and treat them. It is treating a whole human being. So that is my say to a younger man.
Thank you very much, Dr. Aroop. I think I'll add a few words worth. We were just discussing with Dr. Kiran Patel about hydroxyapatite. Hydroxyapatite comes from seashells.
Hmm.
And Chennai is the largest exporter of hydroxyapatite to the international manufacturers. Now, these seashells are collected by the fishermen from the shore and they are sold at 250 rupees a kilo to the slaker. Slaker is the person who gets them into a furnace and converts them into calcium hydroxyapatite, crystalline form. And the crystalline form he sells for 1000 to 1200 rupees a kilo to the distributor. The distributor sells it for 4000 rupees a kilo to the exporter. And in the international market, it is 60,000 rupees a kilo wholesale. And today, Simulan beads and all hydroxyapatite beads are sold for 10,000 rupees for 10 grams. This is something like 16,000% margins. Now, we must not blame the manufacturers because they have a whole range of people around them and everybody has to be fed. Thousands of mouths to be fed and the whole industry to be fed. We have to understand that how to differentiate science from commerce and how to disassociate ourselves from the commercial aspects of orthopedics and be true scientists so that we are able to do a best justice to patients, at the same time maintain a good decent lifestyle. We
ये
have
लैपटॉप का मॉडल कौन सा है?
and Dr. C.J Thakkar both. Dr. Jignesh is speaker and Dr. C.J Thakkar wants to add his words.
पैड
To add him because he is one of
490
the surgeons who has been successfully done his career, and then after that he has sort of started living life, flying aeroplanes and doing adventure after the age of 60. First, Dr. Jignesh Patel, are you there?
Yes, sir, I'm here.
Please, can you?
Hello, sir, I'm here.
Yes, I will spotlight you, and you can start putting a few words worth.
Yeah, just, sir, just by listening all your stalwarts talk, I don't have anything left to me to speak. But what I'm agree with Dr. Gore sirs and others talk that students are not ready to learn the basics. They are ready to learn what their proposed examiner is going to like. Even I have not seen yet any implant manufacturing company. Even I am telling my students, let's go and see them. Today only the local All India AO chairman of my city was arguing with somebody else that we should not give copy implants promotion like that. So there are many things that people don't understand. Just a recent example, my student has been given, I have given him a just general reading topic that pollution and bone density. Since last 1.5 months, he has not been interested in doing this. So ultimately, what I would like to conclude is that it's a long way to go, and as Dr. Gore sir told that as soon as the students are passed out, they are.
Malhotra, please mute your mic immediately.
Anyway, sir, I am concluding my thoughts. I may join afterwards with some few thoughts.
Yes, there is no. Okay. No, I'm still not muted. Dr. Malhotra, is it?
Hello, sir.
Neeraj Malhotra, yes, I muted him, yes. Okay. Come, continue, Patel, please.
Yes, sir. I'm already done. I'm already done. That my thoughts are just matching with all those who have just now told Gore sir and Mukherjee sir. Everybody. Actually, I missed Arvind Diwaker sir's part earlier, half of that part. But what I told that the it's a mass. We have to just go through the very mass movement that students and the upcoming the fresher surgeons should learn for these things, that everything is not behind implants and all these things. Even the our older forefathers, orthopedics, those who are doing, we have to just extract the better things of that. Some of the forefathers may not be that much good marketing persons, so their invention might have gone in the wasted. So we have to search for that also and try to just counter the commercialization. Thank you very much.
Thank you very much, Dr. Patel. I think I will add a small comment here. Important point here we must all understand is that we are all basically commercial people. We need money to run our house, pay our installments, buy gifts for a wife, educate our children, buy a fancy car, a new computer and a phone and like that. And of course, we are scientists and orthopedic surgeons. What we must do is balance science with commerce. One thing I like to advise all the younger orthopedic surgeons is that do not be afraid to charge. Don't say that the hip implant costs 1.25 lakhs, my surgeon's fee is only 5,000. Why? For a PFO, I have charged 60,000 rupees on each side. When the insurance company created a ruckus, I wrote them a nasty letter and they approved the money. When Ram Jethmalani can charge 10 lakhs for an appearance in Supreme Court, as an orthopedic surgeon's experience, you can charge for your surgeries. So be bold and say clearly, this needs efforts. I have studied so hard for it. I have worked so hard for it. I need the money also. So my fee will be such and such. I know senior professors in medical colleges whose entire household runs on the implant company money. Very recently, a young boy messaged me saying that I was offered a job in a private medical college. They offered me a salary of 1.5 lakhs per month as an associate professor. I told them salary for associate professor is too less, 1.5 lakhs. They said, no, you make the balance from the implant companies. Meaning every time I use X company implant, I get 20,000 commission. I use Y company implant, I get 30,000 commission. I operate, specifically target a commercial company. I get my money. So that is actually wholesale corruption. We have to openly say, implant you choose that and you take the risks and responsibilities because the liability of the implant is not with the surgeon. If the implant fails or somebody else's phone is on, doesn't matter. I include it. 1 minute.
Umair Khan, please mute yourself.
Who is on?
Mr. Umair Khan.
Umair Khan, I'm not able to see him. Yes, Umair Khan mute. Yes, I muted him. So I always tell my patients that choice of implants or choice of instruments is yours. My fees is this much. If you can afford me, I'll be happy to operate on you. If you are not able to afford me, I'll refer you to my junior colleague. Now, when this steps down to the younger boys, there is a problem because they do not have the reputation and people are not referred to them from long distances, and consequently, to fulfill their financial needs, they need to operate X number of cases a month so that they are able to at least pay for their bread alone, if not butter. How should he or she solve their problem? This was something that has been hitting in my mind for a very long time. And that is why we have been trying to focus on a combination of academics to overcome the commercial influence of orthopedics, orthopedic manufacturers into our routine practice. All businessmen are there for profits. And today, when I was looking into the international profiting index, it starts from 600 to 1200%, which means any product that you buy, you are paying 6 to 12 times its manufacturing cost, and it sometimes goes up to 4000% depending upon the availability. And this sort of profiteering is more in pharmaceuticals and invented drugs and patented materials. If something is unique and very useful and is invaluable for you, it doesn't matter how much it costs, you have to buy it. Its manufacturing cost may be 1 rupee, you may have to pay 3 lakh rupees to buy it, you will buy it. You don't have an option. So now, how as scientific orthopedic surgeons can we be able to tackle this problem or find some counter solutions to ensure that we are able to what to do, get over it? Is there anybody in the audience who can raise hands or give us a solution about how
तो बड़ी अलग अलग लेडीज आ रही है, मुझे नहीं पता, पर एक यंग सी लड़की अभी आई, वो सबसे ड्राइंग बनवा रही है, देन सबकी ड्राइंग क्या
somebody? Yes, that's gone. Yes, good.
करते रहना देखेंगे.
So again, somebody's audio is varying. Okay, 1 minute.
Aroop Gupta, please mute yourself. We are in a meeting. Please do not disturb us.
Thank you.
Please mute yourself.
Thank you. Dr. Gore, can you please add as to how, as scientists, we can we can help ourselves
Okay.
to reduce.
I would straight away take up this point, and let me be little more blunt about one thing. Prakash, your talk was on a very thin, razor sharp line, and it was away from the topic of the day. I'm sorry to say this. You were covering both. You were justifying the commercialization to some extent. I personally feel today's meeting is not to justify what the companies do or how we can tackle that higher cost or lower cost or whatever. What we feel in our mind is something like this. I will take an example of spine because that is what I do. I don't do any other part of orthopedics, so I will stick to that. Number one, we are taught how to choose a patient for surgery. Nobody teaches us how to manage a patient who comes to you with a changing spine, which could be labeled as a degenerative spine. That is number one. Number two is, as a clinician, once you are after the earning part of it or the surgical aspect of it, you become so dry and you become so sort of inhuman that you're not even interested in the suffering. You probably enjoy the suffering because that is what is going to bring that patient to you for surgery. Now, to start about solution, I can say that I would recommend a simple book to everyone. The name of the book is Advice to a Young Scientist. Now, this book is written by a very celebrated scientist or Nobel laureate. The name is Santiago Ramon Cajal, Kajal. This is available on the net, and most of us have the copies. I have a soft copy as well as hard copy. If anybody wants it, message me. I can send you a soft copy. Advice to a young scientist. Now, what is the advice? The advice is something simple. The advice is whatever field you are working in, please pay attention to who is setting the narrative, who is making the talk, who is making the glamorous topics, who is exposing what, etc., etc. And you will find when you identify that narrative, which is actually counterintuitive, it is not intuitive, it is counterintuitive, and it leads to more cases and more earning and more use of X or more use of Y or whatever. That is not necessarily science. That is exactly where the whole commercial thing starts. And I remember when I started my career, I used to enjoy working, which I still enjoy, but the enjoyment came from solving a riddle, that is, as we say in our branch, where is the pain coming from and why is it persisting? What can I do about it? Now, instead of that, if I'm interested in asking for more investigations, more MRIs, and try this and that. Now, I'm going to come to a very key point. The key point is our teaching has been trial and error. And many of us have been told all the time that unless you fail, you will not succeed. I mean, what kind of logic is this? Absolutely confusing, absolutely wrong. I do not agree with this statement that unless you fail, you cannot succeed. We need to be taught that in today's age, where the technology is a great enabler, you must follow method. And that method will be what we should crystallize. That is the method which we should define. Method for doing X, method for doing Y. And I will give one more example and would suggest one more book, which is a very, very significant book, which I read very often. The name of the book is Checklist Manifesto. Now, this is a book written by Dr. Atul Gawande, who is a surgeon in Boston. He has been a part of presidential advisors in US, and this is a great book. And the summary of that book is very simple. The author says that you make a checklist of whatever you do. Pay attention to those factors that will make you foolproof. That will make you very, very dependable, predictable, and will increase your chance of success. And the last thing which I will say is that all that glamour which is attached to failures should be completely negated by severe criticism. For example, in my branch, there is a very glamorous entity called as failed back surgery. I don't know, we are the only shameless people in orthopedics who take glamour, who take pride in talking about failed back surgery. And we have been so smart that we have always diverted the topic towards failed back surgery. Nobody has ever talked about failed back surgeon. There is a scope to improve our training. There is a scope to improve our understanding of the problem. And the last thing before I complete, I'm going to suggest one more book, which is, I think Prakash, you already know, which is about TRIZ, which is a Russian technology called as Theory of Inventive Problem Solving. Now, I will not tell anything more than this. Only I would say that this is something which will change you completely as to your thinking about solving problems. It could be an engineering problem, could be a medical problem, could be a surgical problem, even could be a social problem. So with this, I would just summarize in 1 minute that all of us are primarily clinicians. Our brain is equipped to solve a problem, and we need to pay attention to narration of our patients and help them. Now, I used to work with a team where we used to work on a fictional project called as Pain Machine. And what we proposed was you take a machine, or let's say you take a mobile phone and give it to the patient. the patient narrates the story, I have pain here, etc., etc. Then you give that phone to the doctor, to the surgeon, and press a button, and the surgeon would suffer the same way in the same location with the same intensity. Then the surgeon would be able to diagnose the thing properly. The other way is to take a doctor's serum, I mean a fictional entity, and inject the patient with the doctor's serum, where the patient would come out with a very, very scientifically sounding narration, like I have pain in my right L5 root because of paracentral annular tear at L4-5, etc., etc. Both these things are not possible. There is a lot which is lost in translation, as they say, in our interaction with the patient, a verbal and non-verbal communication. All these subtle entities must be brought back to clinical medicine. Otherwise, we are doomed. And the last thing which I'll say is that I completely agree with Dr. Aroop, where he has been highlighting something which is extremely valuable. And all of us are we are sort of ignoring those things, which really hurts me. I mean, let's go back to that, and then all other things will automatically follow. Thank you.
Thank you very much, Dr. Gore. You have done a wonderful, wonderful talk. I would like to just summarize two valid points from Dr. Gore's talk. One is the TRIZ, T-R-I-Z. Anybody who wants, you can WhatsApp me. I'll send you the PDF, or just go on Google and type TRIZ, and that will be an algorithm. It's a beautiful chart telling you to identify the problem and how to get to the solution and the methodologies involved. It is not meant for orthopedics alone, it's meant for everything. I have solved my pet problems and domestic problems, engineering problems with TRIZ. Checklist by Atul Gawande is a Bible. And if you have not read it, you must hang yourself. As an orthopedic surgeon, Checklist by Atul Gawande is such a beautiful book that tells you what a surgeon should essentially not or never do. What Dr. Aroop Mukharjee has spoken today is outstanding in the sense that we are called clinicians. We are not surgeons, we are not doctors, we are not allopaths, we are not orthopedic surgeons. We are basically clinicians. And as W.S. Somerset Maugham, in one of his fictional short stories written, a physician is the one who observes the atmosphere, the house of the patient, the social relationship of the patients, the background of the patient, how many people live with the patient, the mentality of the patient, how complaining or non-complaining he is, how compliant or how non-compliant he will be, how he lives. That is the first observation that every clinician needs. Second thing we forget in our speed or hurry or paucity of time is examining the patient. We are sent X-rays on WhatsApp and we say, oh, this will need a TKR, this will need a laser off. Even I have committed this error. Even in this age in my online consultation, patient sends me an X-ray and I said, yes, you need a PFO, you need a unique apartmental, you need an Ilizarov. Come straight to Palakkad, I'll operate on you. But when a patient comes, when I see that he has got CKD and IHD and a very bad cardiac status, I feel scared to operate on him. I don't want to kill him while surgery. I then realized, yes, we have to ask questions. Arthur Conan Doyle was a doctor, and his alter ego was Dr. Holmes. And he projected in Sherlock Holmes, Dr. Watson, and he projected in Sherlock Holmes that the only way to get your right answer is to ask questions. So, all of us have to understand both Dr. Mukherjee and Dr. Gore and learn to ask questions, which means we have to aside X amount of time for clinical examination, which means history 40%, examination 60%. Ask questions, spend time with the patient. Dr. Mukherjee spends close to 45 minutes to 1 hour with the patient. On the contrary, Dr. Diwakar spends less than 5 minutes with the patient because he does only trauma. So he sees a patient, reduces the patient, puts them in plaster and sends them home. I would prefer the Mukherjee way of examining the patient in detail, understanding the problem, knowing every bit of what there is to understand, know for myself what is going to be best for the patient, and then only suggest any management, and surgery per se comes much later. And is Dr. C.J. Thakkar there? Is he listening to us? He's from USA. I think he has put the mic.
Yes, I'm listening to you with great interest.
Now, can you give us
And
words of wisdom, please?
okay, see, I have joined halfway through.
Let me just
And,
let me introduce you, and then you can speak.
okay.
Dr. C.J. Thakkar is a senior orthopedic surgeon from Mumbai, and he has been one of the most prolific surgeons and operators. And once he has mastered orthopedics and has made his money, he decided suddenly to get back to what he loves, and he decided to retire from orthopedics. So he doesn't see patients, he doesn't do consultations. He just is a part of orthopedic groups. He is now flying his own airplanes. He is now in USA and he is now enjoying his life. And he is one of the masters who has mastered both commerce and orthopedics. It's my great pleasure to invite and present to you Professor C.J. Thakkar. Please join us, Dr. Thakkar.
Yeah, thank you very much. So I joined the meeting halfway through, but I got the gist of it. I have been in orthopedic practice for about more than 35 years. 1981, 1979, I passed my MS Orthopedics. And then 1981, I started my practice. And over the years, I was in Sion Hospital as a teacher and in other institutes. And I have seen, the developments, what you say, development means it could be good or bad, both, right? And I've seen the good and bad part of the orthopedics. So there are certain things which I want to tell you. The first and foremost is that our training, as we have said, is very inadequate. And the training can never be adequate for the reason that there are so many different ways to treat one particular, ailment or anything. Just take an example of any fracture. It can be treated in so many different ways. And it is very difficult for an individual to know each and every method. So what happens is by trial and error, you come to a method which you like because it is successful in your hands. And you follow that method and you try to do your best. When a student comes and joins medicine, he comes not with the idea of making money. 90% of the doctors I know do not come with the idea of making money. They come with the idea of serving and learning. The problem I saw started happening is when the medical education went from government and municipal medical colleges where we studied, I think myself, L.Prakash and all seniors, went to private medical colleges. And I thought private medical colleges probably would give better education because they are profit organizations and they would be able to afford better diagnostics and other things. But unfortunately, that didn't happen. They went into bad hands where money making was the only thing. The teachers were not paid well and nobody was interested in teaching. Now, as a student, I remember that we attended classes in different hospitals. We went to different doctors. And then when I became an examiner, the students as somebody pointed out very nicely and really, is a student wants to know what the examiner wants to ask. So he would attend, the last 6 months of his time going to the teacher who is going to be the examiner and study his pattern of examining and would want to pass. So from, the students whom I had very funny thing. One gentleman came and registered under me. And after about 2 weeks, he came and said, sir, I want to, resign. I said, why do you want to resign? He said, sir, these people are not allowing me to sleep. I said, who are not allowing you to sleep? No, my colleagues, my registrars and all that. I said, what do you mean by they are not allowing you to sleep? There is so much of work and you are supposed to do work. He said, sir, no, I don't think I am fit for orthopedics. I said, what is your second choice? He says, pharmacology. Can you beat that? I mean, you are coming to surgical branch and now you're thinking of going to pharmacology. That means what I said, why did you want to become an orthopedic surgeon? He says, because I thought that orthopedic surgeons make a lot of money. Now, if you do not have an idea of what you want to do, naturally you are a misfit. So first of all, being a surgeon requires a lot of dedication. It requires a lot of heartburn. And all of us, some of us become non-operative surgeons because we have more failures. I'm not, aiming at anybody, anybody in particular. I'm just saying that I have seen people very, very aggressive in their initial, days, would operate everything which came their way, and then they became so conservative that they were afraid to operate because they never got good results. So as I said, our training is lacking. Our training has gone away from teachers to companies, which has been very nicely emphasized by spine surgeon Dr. Gore, because I remember, I will not name companies, but they would come with a product, say for example, a tibial nail. And they would say, this nail is good from epiphysis to epiphysis. It can, any fracture, you can just use this nail and it'll work. Now, what is this nonsense? There cannot be any one implant which will work for all the different types of, fractures. But this is how it is being promoted. And then they would get some speakers from so many different places. And any white-skinned person comes and, we get totally enamored. We said, oh, this is the fellow who knows everything. I'll give you a very simple and very funny story about Elizaro surgery. When Elizaro surgery came, when Elizaro came and gave a lecture, we all thought, oh, this is the end of the world. I mean, we can solve every problem with Elizaro surgery. And there was one particular doctor who ultimately retired. He was in Bhopal. And he said, I want to learn Elizaro surgery. I said, why do you want to learn it? He said, sir, this shank screws, give a lot of problem. And the K-wires are better. So I want to learn Elizaro surgery. There is a company called Shushrut. And now they have, sort of merged with Smith and Nephew or somebody. They organized a Elizaro sort of a training program in city of Mumbai. And we all orthopedic surgeons were sitting and listening to those talks. There was one fellow called Theo Canevels who gave about half the lectures. Then we were offered this fellowship, myself and Dr. Agashe, to go to Belgium and learn, Elizaro surgery. And believe me, this fellow, Theo Canevels, was the company representative. He was not even an orthopedic surgeon. And he was pushed into India by Indian company because he was white-skinned and he could talk in Elizaro, whatever he knew about Elizaro. And we qualified orthopedic surgeons from all over the country listened to him and started practicing Elizaro surgery. This is so shameful, so shameful. Another shameful story I will tell you, which happened in IOA Jaipur conference, where there was to be a collaboration with American Academy of Orthopedic Surgeons. So a topic, say for example, fracture of the neck of the femur, an American surgeon would talk and an Indian surgeon would talk. And that was what was decided. I was in the audience, and of course I was also on the faculty. And after my talk, I was sitting in the audience. and the speakers came one after another. One speaker was a physiotherapist. One speaker was a nurse assistant. And why did they talk? Because the original surgeon felt too below his dignity to come to India and talk. So he passed away his slide to his physiotherapist and say, go and give a talk in India. That fellow, those people had come for vacation to India. And it was so shameful. And I just couldn't digest it. I just walked out of the hall. Unfortunately, I didn't have the courage to ask that fellow to stop there and then, asking him, will American Academy allow Dr. C.J Thakkar to give a lecture like this in USA, or my physiotherapist? So this is what we have degraded ourselves as far as the training is concerned. And the training is gone from hands of doctors and scientists to pharma companies or whatever instrument companies or implant companies, and they bring those goras and they implant them on us. Another story or another thing I will tell you about knee replacement surgery is that they came up with this idea of how commerce, fools us. Came up with the idea of patient specific implants. Okay, they came with that concept. What they were trying to do was patient specific instrumentation. Now, why did this whole concept start? Because in the United States, these people said that for total knee replacement surgery, you'll be given X amount of money. And the surgeon felt it was too less. So how to overcome this problem? So first of all, you do a CT scan and MRI. Then you create a jig only specific for that particular joint so that you earn money, number one, from CT scan or MRI. So doctors, orthopedic surgeons started having their own CT scan machines or MRI machines. Then the manufacturing of this particular jig, and then it is to be used on that particular patient. Man, total knee replacement surgery is not cutting the bone. It is balancing the ligament. And you are trying to fool people, and people like Michael Mont, who bloody writes paper right, left, and center in this Journal of Bone and Joint Surgery, writing that, with this particular technique, I am able to do 25 knee replacement surgeries. Before that, I was able to do only 20 replacement surgeries. So there is so much of hospital benefit. And we, like idiots, followed that. So in one meeting, I was opposing that. And next to me was another speaker from Zimmer Company who was supposed to speak for it. He spoke for it. I spoke against it. I put my points. Then I asked him at the dinner, I said, Doctor, do you really believe this works? He says, no, doctor, I don't believe, but I'm supposed to speak this because I'm being paid by the company. So if this is going to be the level of our conferences, our meetings, and our teaching, only God can help us. Now I come to teaching. One more thing is, a surgeon, you cannot make in 3 years. A surgeon, I don't think that I'm a perfect surgeon ever. It takes years and years and years of practice, your failures. But unfortunately, we have always been told one thing, that learn from your failures. I think this is totally a wrong thing. What you should be learning is from your successes. Why did this succeed in my hand? Analyze that. And that will probably teach you much more than why did it fail in somebody else's hand. If you analyze that why did my cast technique for humerus succeed? What are the factors in it? And then you will say, oh, these are the factors. Then how can I replicate these factors in my next patient and the patient after? And then probably you will be able to get better and better in any type of treatment. When we are talking of surgical thing, I don't think, number one, when you have to learn surgery, you have to learn from simple things like a house surgeon will be given a diaphyseal fracture to treat because, these are the ones where a little bit of malalignment is not going to matter much. Then as you become little senior, you will be given juxta-articular fractures and then intra-articular fractures, because as you go from diaphysis to metaphysis to the physis or epiphysis, you require more and more of precision. You cannot become a good acetabular surgeon overnight if you have not done many nailings or many platings of shafts of femur and treated subtrochanteric fractures and other things. So for learning, you have to use implants, you have to learn the technique, you have to master it over a period of time. Those who are doing non-operative treatment, I have tremendous respect for them. But there is a time where you require somebody who will be able to operate on you very well. Now, we were talking of Atul Gawande, and he, I was president of Bombay Orthopedic Society, and when the conference came, I said we should follow his example and develop checklists for each and every procedure. Because as a pilot, we have to follow the checklist, because yes, we think that our memory is very good, but we forget so many things. And this is what exactly happens in the surgery. People forget how to do ligament release, and the knee comes out tight. People do not know how to balance the knee comes out tight, because they have not followed the checklist. And another most important thing Atul Gawande said, which probably was missed out, is that every surgeon should, he said very beautifully that, okay, you take the best of the athlete. Any athlete will have a coach. Why? Because the coach is standing there and seeing him and knowing his, plus points and minus points and guide him. The coach may not be as good a player as the player himself, like Wimbledon, players, but everybody has a coach. So similarly, what he said is that we must have a coach who will come and attend our surgeries, observe us operating, and then find out where we are missing. And this is what we are not doing. We do not have any mentor. Dr. C.J Thakkar feels that, oh, he is the ultimate orthopedic surgeon and he cannot make any mistake. But if he puts L.Prakash and says, hey, Lakshman, come and watch me operating these 10 cases and tell me where I have gone wrong. Or Lakshman, sit in my OPD and see where I am not examining the patients correctly or not taking the history correctly. How many times we have done that? How many of us have coaches? None of us have coaches. So this is what I think, I think I took too much of a time and put in a lot of the things which I probably wanted to say.
Good, beautiful.
But this is what I think we should be doing. Have a coach, travel, meet different people. Do not close your eyes to only one type of treatment. Like, okay, non-operative will never work. It's stupidity. How can you say that? Or operative will always work. Or AO means always operate. These are all stupid things. As a surgeon, you have to keep learning till you die. It's never ending learning. All the best.
Very much. Thank you very, very, very much, Dr. Thakkar. I would like to just add few rejoinders. Number one, you don't reduce operating because of a number of failures. You start reducing operating because either you're getting old, you're getting a little tired, you want to only operate on challenges, or you want to write books and teach, as has been in my case. I was an AO faculty in 1987 in Davos, and even Dr. Junjunwala was my student in arthroplasty when Muller conducted his first hip conference. And I was a prolific 200 cases a month. I operate only about 10 or less a month. Because I operate only tertiary referrals. And at 65, I feel too tired to go aggressively and operate. Surgery is indicated. What our senior surgeons do not understand is that when to refer. सब कुछ मेरे को चाहिए. It's everything I want. Today of my online consultations, 80% of surgical cases who want to come to me to Kerala to get operated, I said, no, I will locate a local surgeon nearby you and refer to him. He will do a better job than me because I am an old man and I will do only tertiary referral cases. So I am doing less number of cases because I am only doing those cases which I feel that my youngsters cannot do justice to it. So primary trauma and primary arthroplasties and all are way beyond a 64-year-old man's repertoire. It is better to be done by younger man because they have to pay their EMIs and they have to pay their staff salaries and they have to run the nursing homes. Checklist part is very, very important. And more than that, it is important that we have to have a theatre protocol. Meaning that whenever I enter an operation theatre, even if I know every staff, I will again say, this is a ritual, let us follow it. I am Dr. Prakash, I am the chief surgeon. I am going to operate on patient so and so. Who is this? This is a limb which I am going to operate. Please introduce yourself. Anesthetist will say, yes, I am so and so the anesthetist, and this is my machine, and all my things are okay. Chief sister will say, yes, I am the chief sister, so and so, and I'm okay. And every single person in the OT will introduce himself, and we'll all look at each other's faces, and then only start. We take collective responsibility for the surgery, just as they do in a flight. This okay, that okay, that okay, and pilot says and co-pilot says yes, 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 yes. We have to ensure that diathermy is working, suction is working, C-arm is working, all implants are there. Very recently, a very senior surgeon in a very reputed hospital had a trouble because he cemented in a 32 cup and they had only a 28 ceramic head, and he put the 28 ceramic head and closed the hip. And then he's asked me the next day, shall I continue with this, or shall I change the cup, or shall I change the head? I said, bloody give me the company's number and I'll screw their happiness. Next thing that happened was today he revised it. He had to shatter the ceramic head and then put a new 32 ceramic head, and company paid for the pulse lavage and the drapes and the 32 head and everything, and apologized and promised him that when any problem happens, they will sort of compensate him for the trouble. So check every single implant and size available on the table before you start.
There is one more thing I would add, Prakash.
Yes.
When Dr. Lad used to say that before you start the surgery, pray and say, let this be the last operation for this patient for this particular problem.
This is not Lord's statement. This is Dr. K.T. Dholakia's statement.
Dr. Lad told us, so whatever, whoever said that, but this is very important.
Whenever Dholakia used to come in IOA conference with the white and white and he used to start his slides, his first statement will be, please ensure this is the last surgery for the patient. Never ever in his life has he to be operated for the same condition again.
Right.
And that is one of the prime lessons. I have seen humerus shaft operated 11 times. And then 12th time, who helped, thankful to Dr. Mario Tangari that we could finally get it united without Elizarov using his Miros clamps. So those are type of surgeries I'm seeing these days. Now the basic concept of this conference or this short event of exclusive 35-40 participants was to check on the influence of insurance companies, the manufacturers, etc., etc., on how it is molding orthopedic practice. Now, whenever you put a big bill, the implant cost is high, insurance company doesn't mind. So long as it's a big sticker, they have no objection. But when you put a surgeon's fee at a higher price, they will always put some objection. Now, proximal fibular osteotomy is a very simple procedure, 10 minutes for each side. And this is a very simple example which happened to me about 2 years back. Insurance patient had an insurance of 10 lakhs. So I put my fee of 1 lakh rupee per PFO, 2 lakh rupees for my fees. Hospital charges were 60,000 rupees. Total bill 2.6 lakhs. And his annual coverage of insurance is 10 lakhs. Now, insurance company people wrote to me saying that even Dr. Trehan doesn't charge 2 lakhs for his surgery. I said, ask Trehan to come and do this PFO. Let him charge whatever he wants. My fees is only 2 lakhs. Again, the insurance company lady wrote to me, please do some consideration, reduce your fees. I said, okay, I reduced my fees to 1,99,999. I have still the emails with me, and eventually they settled me for 1.999 for bilateral PA post with a 20-minute surgery. So, message for youngsters is, do not blame the commercial companies for overcharging. You can charge what you want or what you think you deserve. And you be scientific enough to develop your own methods. Because just now we have a message from Dr. Koshal. Can we patent a treatment plan or can we treatment a specific design of implant? Very interesting question. Dr. Mukherjee has a treatment plan, more than 3 lakh prescriptions going, so many hips saved. Dr. Diwaker has a wonderful treatment plan for ankylosing spondylosis. I myself have treated about 300 patients. Treatment plans in India or internationally cannot be patented. Can I patent an instrument design? Of course, yes. All over the world, starting from Hungerford and Kenna, who patented the knee instrumentation design, you can patent any instrument. But the only point is, even with a 5% modification, any instrument manufacturer can modify your implant and repatent him. I have 18 patents, but I have released them on Google and I have released them on internet free because I want people to benefit from those patents. These patents are not for me to make money. Maybe because I am non-commercial or I have come to an age where I no longer need money, commerce doesn't bother me at all. The basic question here was, in what way does commerce actually affect an orthopedic practice? I know a senior orthopedic surgeon, the past president of IOA, who traveled the whole world on the expenses of a company, plating titanium. And I know, and I have seen, or I have personally seen X-rays.
Prakash, please mute the person named Zoom user.
Muted. And I have personally seen X-rays and ghastly clinical pictures of 20 to 30 of his infected calcaneum fractures. More than half a dozen people in this meeting actually know that person and know those patients. So whether it works or not, you have to treat X-rays. And AO pays you for every implant you use. Or maybe it pays you for all your annual holidays to Switzerland and with your wife and son-in-law, son and daughter-in-law. And that way, who pays? The insurance pays, the government pays, the patient pays. That is not the way to go for orthopedics. We must choose for methods that actually work after a proper clinical evaluation of the patient, as both Gore and Mukherjee have repeatedly emphasized, that we need to know the problem to find a solution. I'm sure that most of the people on this group don't know what TRIZ is. TRIZ. Please keep it in your mind. Search on the net. On WhatsApp groups, I'll send the links again. It's a Russian methodology for reaching from A to Z by a scientific method. You have a problem, you want a solution, you have methods in between. Choose which is the best method and the shortest method to reach the root.
I have a question.
Yes.
I have a question.
Yes.
How many teachers have told you to read beyond orthopedics?
Zero.
Then that's the end of the world. If you do not know what is happening around you in different fields, you cannot be a surgeon. So as a surgeon, you have to know so many different aspects like research, business, analysis, which companies grow, which companies don't grow. You have to learn a lot. None of your, how many orthopedic surgeons read? Ask me, ask people. How many of them read? Even orthopedics. Once they pass MS orthopedics, people stop reading, people stop learning. Only 10% read orthopedics and probably 20% read, besides novels and pornography, some good other things which matter in practice.
Dr. Thakkar, I read 4 to 6 books every week. The orthopedics, science fiction, and everything. And that is what makes.
You are different. I'm not talking about you. I'm talking about an average orthopedic surgeon.
I don't want Amazon. I like and take pleasure in reading more than any of these visual media. Because author takes so much time and effort to write that it and when you read a book, you visualize it in 3D, which is far more impressive than any movie or video. I can learn more from a page of text than an hour of video.
No, see, for orthopedic surgeon, what is important is three-dimensional imagination.
Exactly.
Okay. Now, as a child, my grandmother used to tell me stories about Ramayana and Mahabharata. And when I thought about Bhim, a picture I will form in my mind, how he ate, how he fought, how strong he was. Today, my grandchild has to just put on the TV and just watch Bhim and cannot think about it.
Exactly.
I have to create an image in my mind. Now, this facility is not there in people's mind. When we are talking of, say, complex hip or, say, supracondylar fracture, how many people can visualize it in 3 dimension as to what the muscle forces are and how they move? Because they have not read. They just watch the video and they think they know everything. You have to understand, visualize, and get the 3-dimensional picture and the procedure in your mind, which is not there. We are not teaching them that, unfortunately.
Gore wants to add something. Please, Dr. Gore, come in.
Yeah, I have a comment on this 3D visualization. Since I do transforaminal endoscopy, it forms a very basic aptitude which I need. What I have observed is, like people who are color blind, there are people visualization blind. I mean, seriously, they cannot visualize. They do not know that a structure lies behind a structure or on the side of the structure. And when you try to explain to them that this is lying behind it, they say, how do you know? So I say, well, what is there to know? It is like that. That's the way the anatomy is. And you can't argue on that. I mean, if you can't visualize properly, you are unfit to be a surgeon. You better go back to non-surgical methodologies where you would probably deal more with pharmacology rather than surgery.
No, I'll add something here. Even today, at this age, every night before I go to sleep, if I have a surgery the next day, I will visualize the whole surgery in 3D. I will visualize every single complication. I will have all complications in the surgery. And 6 o'clock when I wake up, I'll wake up with an image of me doing the surgery properly. Then I'll go it and finish in half an hour, 45 minutes. And the nurses will say, sir, the last surgeon who did the same case took 2.5 hours. How could you do it in half an hour, 45 minutes? Pre-operative, that's what is stress. That is what is Atal Gawande. That's what, just exactly what Dr. Thakkar and Dr. Gore told us. That planning is 90%, execution is only 10%.
How many surgeons do carpentry?
How many times do I do carpentry or how many surgeons?
No. So John Charnley had the whole, workshop. Have we ever taught anybody carpentry in our teaching? What we are is glorified carpenters. Ultimately, we are glorified carpenters.
Be a gardener, never be a carpenter.
No. Basically, gardener is one part of it, but to teach them proper surgery, only AO taught us that, okay, you do on the bone models. Otherwise, nobody taught us any of those things. How to put in a screw.
Carpentry in prison.
But that's what I'm saying. Our training is lacking in so many things. Like Dr. Gore said, okay, visualization. Do we have an aptitude test before we join orthopedics that are we fit to become orthopedic surgeon?
No, not at all. Other doctors can join orthopedics. What Gore mentioned was, it is actually called 3D blindness.
Exactly.
Meaning that people lack the depth of purview because of lens and what you call retina distance being skewed because of the facial asymmetry, that they cannot assess the depth properly. It is not actually glaucoma. These are the guys who trip on stairs, who cannot see far distances, and who cannot differentiate between 10 meters and 100 meters. So for them to get into the lens and see the endoscopic part is virtually impossible. For them, everything will be blurred.
No, I didn't mean that. There are tests to find out the aptitude for 3D visualization. The simplest test module which is available on the internet, it is called as Purdue University 3D visualization test.
No,
There are
what
many more. I have used many of them to sift through the people who apply for training to me. I tell them, you are unfit to do endoscopy because you cannot perceive the 3 dimensions. I'm sorry, I won't waste my time on that.
No, you are saying exactly what Dr. Thakkar says, that how many such tests are done to admit people to medical colleges? We have seats for everybody. Scheduled caste, scheduled tribe, backward caste, handicapped, defense person, everybody. But has anyone done a test to see if you have an aptitude to be a proper doctor or endoscopist, or can you do 3-dimensional studies? No. So unfortunately, we get up a lot of people who may not be fully competent to be the orthopedic surgeons to do the best service to their patients. And consequently, our patients suffer. And what happens? Commercial companies send in the reps, and those reps do the surgery. And then our doctor stands by the side and sees the show, magic show, and goes and collects the fees. So that is not what.
But in Maharashtra, there is one fellow who is he was working for a surgical company for interlocking nailing. He goes all over Maharashtra, and the surgeries are booked according to his convenience and not surgeon's convenience.
I think now we'll open the house to other surgeons. Anybody has got any comments, suggestions, questions? And I think Aroop Mukharjee has to say a statement now. It is his time. Dr. Aroop, please join us and unmute your mic.
Yes. Can you hear me now?
Yes.
Now, see, these are the personal experiences of the people who have been in the field for many, many years. And these are their take. And this was the message they wanted to give to the younger people. I don't consider myself old. I don't consider myself an old man. I still am learning. I am still formalizing or visualizing.
Please unmute, please mute.
I am still
Dr. Jignesh.
Yes.
I am still upgrading and optimizing my prescription, my way of understanding, and still I am going through the books, especially the books from the other faculties, what they think we are lacking in. Now, I have been sharing my thoughts in the group with the other members also about the disease and what is the basic difference between a doctor and a scientist. A doctor uses his brain, but as a heart of compassion. If I can't come to a conclusion why my patient is still suffering, then I look back at myself, that I am the person who is not able to understand what my patient is suffering from, or I am not able to hit the nail on the head. So what are the causes and what we need to manage is the little message. Now, get the best knowledge of the disease. I'm not talking about trauma. Even in trauma, we need to know that this traumatized person already has this and this blah, blah comorbidities. Even if he is a diabetic old man, his trauma is different from a young man's trauma. So then what are the consideration in your brain in order that will benefit this elderly person rather than a young man? Now the knowledge of the disease, now the extent of the disease. Now if patient is suffering from other metabolic diseases, what are the other organs which are equally affected by the disease? Now, what are the factors promoting the disease? So we need to discuss it with the patient, that in order to be in a follow-up, you should know that these are the things which is increasing your disease, and these are the factors which is controlling the disease. So he should know exactly that what is harming him and what is benefiting him. So that needs a little time for the doctor to sit. Now, what are the drugs and what are the tricks to bring quick remission to the problem? If the patient comes with a severe disease or severe pain, then how he is on telephone, that last night I was suffering from severe pain or whatever, from acute vertigo, or I am not feeling well, whatever, or my sugar shot up, then how to bring a quick remission to the problem? Now, also, when I am talking to the patient, I should be able to fairly predict what are the sequence of events he has been through and what are the sequence of events he will go through in the next years. So then they look at me like a Jyotishi or an astrologer who knows that I had a heart problem, I have a blood pressure issue. How do you know this? And this fellow is so confident telling that your brother and sister will be having blah, blah, blah. It is not, it is science. It is not an astrology. If you read your own books, but your book should also have other subjects like controlling hypertension, like controlling diabetes, like controlling thyroid disorders, like controlling acidity, like how much exercise, what exercise, and when to do it, when it is contraindicated, and that you have to share with the patient. Now, also discuss with the patient how to maintain a long remission of the disease. The patient is concerned that I had an acute attack, I'm suffering from it. How can I make sure that the next attack does not happen? So that also you have to write down or discuss with the patient. Now, another thing, what my patients are concerned is about the safety profile of the drug. And the safety profile of the drug, every drug has an adverse effect. But I always tell them in a simple word that your mom's kitchen has a knife, has fire, as well as chilies. And these three things can harm you. Did it harm you ever since you have grown up? She exactly knows how much chili, how much heat is to be used in making to cook a delicious food. So similarly, a doctor knows sometimes my patient's body will not respond as per prediction. So in that condition, I will have to put your blood test or investigation to detect the early adverse effect. So if you sleep, take thinking that my drugs will be safe for the rest of my life, That's not true. What I want to say, that in spite of my experience and best effort, there are patients who suffer from adverse side effect, but their adverse side effect don't happen abruptly. They give us hints, and for catching those hints in an early stage, you have to subject yourself to certain investigations, like an ultrasound once a year of the whole abdomen, like a TMT once a year for a cardiac vulnerable patient, like a chest X-ray for an asthmatic patient, like a HbA1c of a diabetic patient every 3 to 6 months, like a thyroid profile for a hypothyroid patient, like if the patient is complaining about gastric disturbances, then once a year, if upper GI endoscopy is done, that is also to be taken, or especially in people who have a history of ulcer bleed. Now, role of nutrition and physiotherapy in maintaining the remission. How much nutrition and what is the role of physiotherapy in maintaining the remission, and what to do when you suffer from an acute attack? Stop physio. Don't do exercises. Keep yourself warm and comfortable. Rest will make the same medicine more effective, what you're taking. If you're running around, the same medicine will be less effective. Now, what are the factors affecting the disease flare-up? What are the mental stress? What are the physical stress? What are the food stress that will make it worse? And finally, I just want to peep inside the mind of the patient. What is his expectation from the treatment? And myths in his mind. There are certain myths that no, he has given me 2 milligrams steroid, which is harmful because his forefathers have told that steroid is bad, or he is given me blah blah medicine, which is bad. He has given me too many medicine, which is bad. Now they want that I have been all right throughout my life. I am a very disciplined person. My food is regulated. Why should I suffer from a disease? But you cannot. Then I ask them the question, why your color is dark? Because one of your father or mother is dark. Why you are obese? Why you are behaving like this? Why you are half bald? Why you have a behavior pattern like this? Because we inherit so many qualities from our forefathers and parents, we also inherit disease. But the manifestation of the disease may be different in different siblings at a different age and according to their occupation as well as environment. So if one brother is living in a very polluted area and one brother is living in a relatively serene area, they will have manifestation of the disease at a different age, as well as stress, whatever you say, monetary stress, familial stress, mental stress, or these are the things. Now, what makes me think that this patient is not having any compliance? What are the patients who have a poor compliance? Because either your medicine is not economic. We always think of the same economics or family economics, family financial as we belong to. But there are poorer patients who even calculate the cost of per day therapy. And they say, this doctor has told me that I have to continue the medicine for the rest of the life, which is a bad news. If my medicine is more expensive, then they will fall out of the compliance, fall out of follow-up, because they calculate that I can't afford this. So I will have to step down a little and to think in their terms and in their view. Now the medicine should be effective. If you write medicines which are not effective, but only expensive, you cannot ask for a compliance for a longer time. Now, medication available to all the cities is another criteria. I will not write local medication. I will not write a medicine which is very expensive. As we know, the same brand, generic medication is available with a different price tag in the same shop, but everything sells. But I will not go to the generic also, but I will go to a modest price, well-known international market product which is available in my neighborhood. Suppose I want to give steroid, I will give Medrol because that is the most popular name in, and anybody who can see the prescription, they can point out that this is a steroid. I make no effort in hiding the fact and giving it in a different name, and promote the patient and let the patient come and talk to me. Why have you given this? So every medicine has a reason and a frequent. It is only the first meeting which takes a little time. The next meeting is a lesser, and subsequent meeting can be done also, provided his blood tests and physical ability and symptoms for which he has come are all addressed properly. So this is, in a nutshell, I want to share with my less experienced person that this is the way I manage my public dealing. And I invite my patient or encourage my patient always to take a second opinion. Initially, I had a rubber stamp also. It said that the medicine is given in that any medicine can have a side adverse effect. But because that is the reason you need to come with me timely with investigations, and patient is encouraged to take a second opinion. So my juniors also asked, why do you write this or encouraged to take a second opinion? I only said, nobody knows about the disease better than me. Let them also, the world is not interested in giving a free advice. World is interested in catching his money. The moment they get the 2 knees done, the surgeon does not want to see them. The moment they do the spine and the patient comes back again with the back problem, they don't want to see. They will get another MRI done or something other, or they will not like to see the patient again. This is avoiding the problem. I will like a patient who will come and tell me the inside story of his experience, so that this should not happen if it is a misadventure or a bad experience to any other patient. So I can always say that a trained doctor, an educated doctor, is the best person to understand somebody's problem in a scientific way, provided he has a compassion to treat his problems. That compassion is necessary, and that compassion should be a part of pre-medical examination to get an entrance in MBBS. That compassion test is missing, and that is all the problem of it.
Beautiful,
Thank you,
Dr.
Prakash.
Beautiful, 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 beautiful. Well done. Excellent, excellent talk. So I think we have got only 5 minutes more. We have run 2 hours for this meeting. So let me summarize. Dr. Gore has told us very important points, 2 points. Checklist by Atul Gawande and TRIZ, the Russian method. Please Google them, and I'll post both these links on the WhatsApp groups. Dr. Thakkar, C.J. Thakkar, my very old close friend, now a flight pilot, who is doing the checklist every day and is enjoying his life in US. I wish I could enjoy my life like him. Has told us some very specific points that surgery is not bad. Surgery is not wrong. All surgeries are not non-essential. Surgeries are needed when they are needed. You as a surgeon must decide when to operate and when not to operate. And be like Aroop. Be a diagnostician and a clinician to understand and find out the problem. Be a Sherlock Holmes. Investigate. You can investigate and you can sort of ask questions. You can learn. You must read. And the consensus of teaching here has been reading. It is very unfortunate that orthopedic surgeons have lost the habit of reading. We do not read books, which is very, 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 very bad habit. We are so happy watching YouTube videos of surgical techniques and so happy listening to orations and lectures and even recorded meetings like this that we forget to actually read the print. Please understand that the mind works in a different way while understanding the printed word and visual and auditory objects. So visualization auditory is a shortcut to reach the cerebrum where you get the gist of the subject but not the depth of the subject. So your perspective is wide but your angle is not deep at all. Whereas when you read, you want to know what is in the author's mind. You actually visualize in your own mind in 3 dimensions what the author has written. And that is important. For example, Mukherjee even now writes his prescriptions with hand. He has got a very clean handwriting and he writes detailed prescriptions. And it's a pleasure to read those prescriptions. And the pharmacist or the medical shop will never do a mistake. And Mukherjee reads. Dr. Arvind Diwaker reads. Dr. Gore, Dr. Thakkar, for all my friends, spend a lot of time reading books. Read on net or read physically, doesn't matter. Read. That is one lesson for today. Number two, before you advise any surgical procedure, one must understand when not to do it. And more importantly, if you are doing it, how to do it well. This is not advising against commerce. Commerce and orthopedics are so intertwined that we cannot separate them. Unless the implant manufacturers make implants, you can't operate. And unless you operate, implant manufacturers won't be able to make implants. When they make implants, they have to sell it at 6x profit or 10x profit. And that's their business. There's absolutely no way you can help them or you can help the economic, socio-economic fabric. Insurance is there, which is spoiling the things. Private nursing homes are there, corporate hospitals are there, and all these have their effects. We have to balance. Again, not operating too much is not a sin. Operating too much is not a crime as well. You must balance. You can have a practice like Dr. Diwakar or Dr. Mukherjee treating 90% of patients non-operatively, or you can have practice like Dr. Gore or Dr. Thakkar who operate 50-60%, who used to operate 50-60% of their patients operatively, or you even have like me, I had 20 years back, but I used to operate 90% patients who came to my clinic. It's your choice. Whatever you do it right. There's no pressure to operate when it is not indicated and not operate when it is indicated. A scared surgeon who's scared to operate is a coward. Dr. Gore has done and perfected a lot of work on lumbar canal stenosis. And when I saw his videos and saw his Zoom meetings, I was shocked and surprised Because lumbar canal stenosis, I thought that any surgery used to fail. But he has gone endoscopically and just opened up that particular area which was causing obstruction and made the patient dramatically right. So that is magic. Dr. Aroop Mukharjee has treated avascular necrosis and medically, and I have seen grade 2 and grade 3 reversing in 3 years and joint space reappearing. That was magic. I had an opportunity to visit Dr. Arvind Diwaker, and there were 6 supracondylar fractures in his clinic waiting, and it took less than about 2 hours, 1.5 hours to quickly finish all the 6 patients, put plasters, no CM, no X-ray, and after we had our lunch only, we saw the post-operative with the post-production X-rays, and every single supracondylar was perfect. So practice makes a man perfect. Age and wisdom gets us the logic and magic. Commerce doesn't. Knowledge does. So I think I should sum up today's meeting exactly 2 hours now. That number 1, read, 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 read. 2, knowledge is power. More knowledgeable you are, more powerful you are. 3, don't be arrogant. You don't know everything. Actually, you know nothing. 4, unless you unlearn, you cannot learn. So once you have fixed ideas, new ideas have no space to enter. So your brain is like a hard drive. If it is full of junk, no new information can enter in. So occasionally reformat and then get in new information. And lastly, listen, keep your ears open, read, analyze and see the information, separate the wheat from the chaff. Now I will ask Dr. Gore and Dr. Mukherjee to conclude and they will finish the meeting. So Dr. Gore, your last words, and Dr. Mukherjee, your concluding sessions. Dr. Diwakar has gone for lunch, gone for his dinner, so I'm not inviting him. And Dr. Thakkar also, American time is, I think, odd for him. Dr. Thakkar, are you here? Are you here, Dr. Thakkar?
Yes, I'm here.
Please join in.
Yeah, I'm waiting for them, Dr. Gore and other people to say their words.
They all come, they all come, they all come.
Okay, my quick summary is like this: that be rebellious, do not accept every time what your senior says, apply your mind and enjoy your work. Thank you.
Dr. Thakkar, you have to unmute you have to open a video, only then you will come online.
You want me to open the video? Okay.
So that you can,
Yeah.
there you are.
No, I agree with Dr. Gore that enjoy our work, because if you don't enjoy it, we are never going to be able to be master. Enjoy our work.
Dr. Mukherjee.
I think my message is plain and simple. As a scientist, don't believe your teachers also, unless and until you see it in your own eyes that this works. I have seen periarthritis people crying in pain because they have been advised physiotherapy and exercise, and they don't want to go there. I have seen patients of CRPS or RSD crying in pain. They don't want to see the physiotherapist because the treating doctor is very inconsiderate. He does not try to understand why this therapy is not working. If your teacher has told you that exercise resolves your periarthritis, see it yourself and you believe it, then you implement it. Don't make your patient suffer just because your teachers told you like that. So you're a scientist, you have a doubt, you have a right to doubt me, you have a right to doubt even the books. This is my message.
I entirely agree there. Two things. All the books, there are so much copies. All the articles, people just copy without understanding. Hard bed for back pain or slip disc. one stupidity, and no pillow for neck pain is another stupidity. So don't believe what is written in the journals, because people just copy, and the more the references, more the copy work, and more without understanding.
I'll
This
conclude.
is my message.
I'll conclude session. Thank you all very much. We have done 2 hours of freelance talking. And today's final conclusion is, as a scientist, we must have an open mind and we must unlearn to learn. Nothing is fixed. Nothing is absolute chiseled on stone. Everything is flexible. Be open, assess, evaluate, and decide if it works. Try it on yourself. Let me give you a very, very small example to close up. I have suffered from 3 repeated attacks of COVID. Despite 65, I am sexually active. But suddenly I found that I had erectile dysfunction. And for 2 months, even with the younger girlfriends, I suffered. And that made me sexually very, very humiliated. I searched the net, I couldn't find anything. It was before erectile dysfunction has been described by these people. Finally, I called my friend Diwaker, the great pharmacologist. He said, nothing doing. Start Tadafil in the morning and Tamsulosin in the night and see the results in a week. I said, what is the combination of Tadafil in the morning and Tamsulosin in the night? He said, don't ask me questions. This is my personal experience, it works. And actually, all I had to do is start up 20 milligrams in the morning, something for, and Tamsulosin in the night. One is alpha 4, one is alpha 3. And somehow these 2 things work in combination. And they are a magical remedy for erectile dysfunction from long COVID. So keep an open mind. Don't think the physician knows everything or doctor knows everything. Don't depend on the Google for teaching you medicine. Learn, 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 read, read, read. Attend all these webinars. Meet your seniors. Unfortunately, live conferences are not on now, but when they are, go there. And more than the lectures, you learn from the cocktail parties and dinners in the evening by meeting your professors. And teach and learn, unlearn to learn. Thank you all very much. We had an excellent evening, 2.5 hours of beautiful learning. And thanks to Dr. Gore and Dr. Diwakar and Dr. Thakkar and Dr. Aroop for being such an excellent faculty. Thank you very much. Bye.